We never was. Yeah. We never did it.
We want to welcome everybody here, we've got limited time with, the great Health and Welfare Committee in the Senate. And we wanted to do this, jointly because this is an issue that I think is, pretty important to both committees and particularly with where we're headed. I'll just speak a little bit and then turn it over to the Chair of Health and Welfare, Senator Lyons.
Oh, okay.
I've seen in my community and around the state consolidation of healthcare services across in my county. Our FQHC just closed a doctor's office in Stowe, and all of those patients are now have to go to Morrisville to get their services. There is talk at my local hospital of closing a birthing center, which would force everyone to go to Burlington or to some other community for births. And as we do this, particularly for low income, older Vermonters that have trouble driving particularly at night, and that transportation becomes a real issue. And I would just say in the transportation area, what we've heard from the public transit people is the number of people providing rides is significantly less than it was pre-COVID. But there is some ramping up again. And looking forward, facing Medicaid cuts and reorganization within the healthcare industry, we're concerned. And so at that, I will turn it over to Senator Lyons and have her speak.
Thank you. Thank you, Senator Westman. Senator Westman actually was the one who suggested we meet together on this really important issue. Our committee continues to hear about the need for transportation, particularly in our rural areas where we have such a geographic distance between home and care, hospital and outpatient care, or community-based services. Our committee is acutely aware of the needs, but we can't do that alone. And so it is critically important that both transportation and healthcare work together, especially for those, as the Senator Westman indicated, especially for those low income, those who are disabled, and those who are older and can't move across the state on their own. So as part of the work that we've been doing, we've been looking at a coordinated plan in our state to actually evaluate what is needed. At the same time, we know that the needs are very great right now. So we need to take this step forward together to identify what we can do, either as a transportation committee, as health and welfare committee, or together. So this is a collaborative process. Our committee is going to be here until 9:45, and then we'll leave. So we're not going to leave it all in the hands of transportation, but we'll give them as much as they need to get the work done.
At 9:45, we plan on moving back to the Transportation Committee and continue taking testimony.
So before we start, could we just go around and have our committees identify themselves?
Absolutely.
That would be good.
Sure. Hi, I'm Senator Becca White. I'm the Vice Chair of Transportation, and I serve the Windsor County District.
I'm Andrew Perkslick, Senator from the Washington District.
Pat Brennan, Senator from Grand Isle County.
And I am Rich Westman. I'm the Senator from Lemoyle.
Ginny Lyons, Chittenden Southeast, and I chair Senate Health and Welfare. And then the rest of the folks here are Health and Welfare.
Hi, Senator Martine LaRock-Ulick, Vice Chair of Health and Welfare, and I serve Chittenden Central District.
Hi, Ann Cummings from Washington District, right here.
Senator Larry Hart, I represent Orange County.
I'm Sam Douglas, Senator from Orleans County, and I have the most fun job in health and welfare. I'm the clerk.
Yes, we do.
And he keeps us honest, which is great.
We,
So,
with a discussion with Senator Lyons, we thought it would be good to start off with the healthcare providers and
so I don't know, Michael or Devin's not here. Oh, there she is. Okay. Did you have an order or are there folks who want to testify together so can come up? It would start, I think, with Devin Green and Michael Costa, unless you had a different idea about who should be coming up to the table first. How?
Okay, if I may, Senator.
Okay, yes.
I'll start off, but then I brought folks from our team to talk about the.
Would you like to be together?
We'd love to be.
That would be great.
if you all wanted to come up at the same time and sit, that would be great.
Bring another chair if you'd like.
Need a chair.
I can bring some.
So good morning. For the record, Michael Costa, CEO of Gifford Healthcare.
Anthony Knox, Blueprint Program Manager for the Randolph Health Service Area through Gifford Health.
Great. And so it's important to remember Vermont's been on a healthcare journey for a long time. And the ultimate point of that is to increase access to care, reduce costs, and make sure that people get high quality care and live thriving lives. I think when you do this work for a long time, you realize that there's much more to health than healthcare services. Frequently, people need things that aren't done at a hospital, aren't done in a doctor's office to get what they need. Particularly during COVID, we saw sometimes the things people needed was to not feel so isolated. They needed relationships. Sometimes the best medicine is a good job. So people feel like they have dignity and it reduces anxiety about economic uncertainty. And many, many times what they need is transportation, particularly in a rural setting. If people can't get access to care, if there's a reduction in their transportation options, it creates a ticking clock for some sort of healthcare crisis. And ultimately, you get the opposite of what you want. You get people delaying care, their health outcomes go down while cost goes up because they're not able to access the right care at the right time in the right place. We are very worried about that because at Gifford, we believe at some point in time, we're going to get to a future where we're paid to take care of our community. And at that point, it's about figuring out what they need and when they need it. And if you can't get transportation on a consistent basis, or if your roads aren't in a condition to get people where they need to go, you're going to have a significant problem. We know this because we see this all the time right now. And so I would invite Anthony to talk a little bit about our patient stories and what we do at Blueprint, because we view transportation funding and transportation support as a vital part of the healthcare ecosystem.
Thank you, Michael. Yeah. So again, I'm Anthony Knox, and I oversee the Blueprint for Health team that supports individuals in the majority of Orange County, a little bit in Windsor County, and a little bit in Washington County, just based on where our health centers are located. And the team that I oversee, we support individuals with their social determinant of health needs. These challenges can be faced can include food insecurity, financial barriers, and other non-medical areas. But transportation is a real problem for Vermont, but even more so for the rural communities like the ones me and my team serve. Approximately 1 in 5 individuals who seek support from the Blueprint team state that transportation is a problem for them. Challenges that individuals have stated they experience with transportation include not having a vehicle or do not have the means to own or operate their own vehicle, having a vehicle but are unable to meet necessary maintenance requirements and thus the vehicle is inoperable, not having enough money to purchase gas for their vehicle, and then just the inability to have a driver's license. These individuals need to rely on other means to be able to get themselves to work, school, medical appointments, and other areas to meet their physical, mental, and social needs. Ubers, Lyfts, taxis are not widely available within the communities, and most individuals don't have the financial means to be able to pay for them. In most instances, these individuals also do not have reliable support from family and friends to be able to meet their needs, and access to public transportation is essential for them. Having said that, public transportation is woefully limited for the majority of Vermonters. While there are some public transportation options scattered across Vermont, there are significant issues with the current public transportation model. The range in which for areas in which people can access these public transportation models are not available in most rural areas, including bus stops that are miles and miles away from their homes. There isn't access to public transportation in the evening and on weekends. And while transportation options to be able to meet shopping and other social needs are very limited across Vermont, there are additional resources for transportation to and from medical appointments. These rides are primarily provided by volunteers from different transportation companies and social service agencies. In most instances, these rides are only available to individuals who are on Medicaid or Medicare. So, those that have other types of insurance don't have access to this. These rides are only available during limited hours in the day, which creates challenges for scheduling appointments for the individuals. Most situations do not allow for early morning or late afternoon appointments. If the person is able to utilize this ride service, they usually are unable to use the same ride to go to the pharmacy to pick up their medications to meet their medical needs. The ride is traditionally just to be able to transport them to and from the medical facility. In addition, if it is discovered that the patient does own a car and are trying to utilize one of these rides, the ride will be canceled, regardless of the fact if they don't have the means to actually operate the vehicle. The only way the person would be able to get an exemption would be to have a written statement from a garage that the vehicle is inoperable, which generally means they need to figure out a way to get to said garage and get that written statement. While there can still be opportunities to have these medical rides, volunteer support has declined significantly since the start of the COVID-19 pandemic. While we are no longer in a global pandemic, volunteerism continues to be a struggle for organizations. Some reasons include the lack of reimbursement or low reimbursement for mileage using personal vehicles. Volunteers don't want to use their own vehicles and want to use company vehicles, which are just non-existent. Their availability is very limited, including not being available for evening and weekends, similar to other public transportation means. They need to be scheduled days in advance and are unable for same-day appointments in the event that a person needs to get to their doctor. Volunteers are unable or unwilling to travel on extremely rural roads that are not maintained properly using their personal vehicles. And there are a lot of cancellations at the very last minute, and they don't call patients to let them know that, in fact, their ride has been canceled to hopefully allow that individual to find another ride. Transportation organizations should not have their funding cut or eliminated. They need more funding. Well, when public transportation's currently small box does work for a patient we have had some success stories. Patient T does not have the ability to obtain a driver's license. Because they fit in the situation where they can access public transportation, they're able to get to their medical appointments, to remain healthy, obtain the needed prescriptions, as well as be able to go and do their grocery shopping. Patient M had not been able to get to a necessary colonoscopy for their age. With the help of local public transportation company, they were able to attend their appointment and were provided a ride home after the procedure. Luckily, there was a volunteer that was able to assist with the transportation back and forth. We have an elderly living home that's just down the road from Gifford Healthcare. But individuals who live in that home are unable to walk to get to their appointments. Some can, but most of them don't have that opportunity. But luckily, there is a bus that does allow for transportation to and from, so those individuals are able to. So those are just a few, stories of where public transportation, when it works very well. At times, individuals have had to utilize emergency transportation services like ambulances in order to seek non-urgent or outpatient medical care. In some situations, it is necessary for an ambulance to transport someone from their home to the hospital and back. In other situations, if the person was able to ride a bus or utilize a volunteer to seek their non-emergent medical treatment, this would allow ambulances to be readily available for actual emergent situations. Public transportation companies across Vermont should not have their funding impacted, and they should receive additional funding. This additional money is needed to support the following: increase the area in which individuals can access public transportation, increase the times in which public transportation is available, including evenings and weekends, increase the number of paid staff to work at these organizations so that we don't need to rely on volunteers, and then provide appropriate mileage reimbursement for said volunteers when they're using their own vehicles.
Just the one thing I would add is when I take a look at the Oliver Wyman report and the future of healthcare in Vermont, there are barriers to care that hospitals need to address and clinics need to address. So for example, in Gifford, we're taking a hard look at the way we schedule patients, the way we do access care, because there's stuff that we own where we create barriers that don't make sense. And I'm doing that because it's the right thing to do and people need care. But I worry that if we don't respond right now, that some of the infrastructure that Vermonters need, like hospitals, could go away. And when I think about transportation, that infrastructure, the way our roads work, the way our bridges work, like if they're not kept up, that creates a long-term barrier to care. And so I really appreciate the focus both on healthcare transportation and the infrastructure of the state, because I think to have that, those are the building blocks of good health that we take for granted. But if we didn't have them in the right shape, they create a barrier that's really hard for people to overcome. And having worked for Gifford, which has clinics all over central Vermont, and then Northern Counties Healthcare, which was all over the Northeast Kingdom, that infrastructure is really important to people. And it's a part of getting things right for people from a healthcare perspective.
Thank you. I don't know how we want to do this in terms of questions, because there are a lot of questions around the table.
And
Our time is so limited.
do you want to get Devin? And then
I think we'll just keep moving with this, but I will say the one, thank you, this is terrific, and Devin. But when you mention Oliver Wyman, obviously there is a recommendation in there about emergency medical transport. And so part of what we're talking about is coordination between the emergency transportation availability and then our more local daily needs. And so I won't bring up that whole, but there must be a way to pull those things.
I can give you one simple example of, because one of the things I've said to the team at Gifford, because I've been there for 6 months, is that we're not going to be defensive about that report. We're going to be leaders in healthcare reform. And so when we've reached out to our local EMS to say, can we analyze every case that goes to Dartmouth?
Yeah.
We figure out which one should have stayed here. Yeah, I know the report causes big picture anxiety, but can we pick practical things that we could actually work on? Because sometimes if you're living in Braintree and you got a broken ankle, patients have choice in where they want to go, but we can handle that at Gifford. You don't need to put that that ambulance out of service for 4 hours going to Dartmouth for something that your local hospital could handle. And so we're trying to do that collaboration of what can we as Vermonters do right now to try to address some of the big picture themes in that report.
Thank you. It's great.
Will there be a chance for us to ask the medical providers a question as a group, perhaps?
They've got 20 minutes. So we're with them, and we're going to break out and have everyone in our committee. So we're able to, and I'm sorry but we're really on a tight schedule to get people in and out of here so we can hear from everybody.
Yeah, and thank you for that. And then, so I would suggest write your questions down. We're going to have questions too going forward. This is the first conversation. So.
It's not the last we're going to be talking about this.
Darn. Okay.
Thank you.
Let's solve it today.
Thank you.
Thank you. Welcome.
Hi, good morning. Devin Green, Vermont Association of Hospitals and Health Systems. Thanks for having me in here today to talk about the provider perspective on transportation. Hospitals have seen transportation issues for quite a while now. They've long seen it as a barrier to care. But this became acute post-COVID when we were having capacity issues and we would find a placement for a bed and then we would be unable to move that person to the bed, further exacerbating the capacity crisis that we were in. And so we are really invested in finding a solution to the transportation issue, both at the preventive level. So, people have rides to their appointments so that they don't have to go to the emergency department later, and then at the EMS level as well. I'll just repeat what Michael Costa said about Act 167. Transportation is one of the major findings of the report. The report talks about building infrastructure for Vermont, and it talks about housing, and it talks about transportation, and it talks about workforce. And I do think the report meant transportation broadly, both the EMS space and the non-emergent medical transportation. So we support those findings, and we would like to work on building that out. I'll say that EMS is in the process of doing a report and building a 5-year plan. So they have Act 157, and they have an advisory committee that's meeting with stakeholders. They're in the data gathering process, which should be ending around now. They said April 2025. And their report will be coming out in December of 2025. So that should give us a 5-year plan that we can work from. But that does open up the space of non-medical transportation. And we do think a process there would be really helpful. I think it's important to understand what the patients want and what the providers see. I think as highlighted by the Gifford team, there are areas for improvement with the non-emergent medical transportation, and potential flexibilities that could be created. And so we really support a stakeholder process to address the non-emergent medical transportation piece. And then hopefully those folks can talk with the EMS, yes, and we can have a nice coordinated and integrated statewide plan.
Thank you.
And that's what I have.
That's it. So 167 for purposes of transportation people is the link to the Oliver Wyman report. So it was the bill that asked for that from the Green Mountain Care Board, and there's still other things going on with it, but having the EMS report will be great. And it sounds like our two committees will be working together for a while. Yep.
I suspect that's true.
Okay.
I wish we could snap our fingers and make it all better.
Yeah. No, these guys are going to do it for us.
At this point, I think it would be good to hear from public transit, and Caleb, if you would come up, and hopefully we'll finish the 3 segments that we've got here, and there will be questions for us jointly before quarter of when you have to leave.
So good morning, and thank you, Chairman Westman and Chairman Lyons, and distinguished members of the Senate Committees on Transportation and Health and Welfare. My name is Caleb Grant. I'm the Executive Director of Rural Community Transportation, providing transportation to the Northeast Kingdom and Lamoille County. I also serve as Vice Chair of the Vermont Public Transportation Association. I'm here to emphasize the importance of Medicaid-funded transportation services, which many of our most vulnerable residents rely on to access essential health care. With potential Medicaid cuts, I want to highlight how these reductions would significantly impact our ability to serve Vermonters who need this service the most. For many, public transportation is not just a convenience, it's a lifeline. Medicaid-funded transportation, or NEMT, helps individuals get to medical appointments, specialized care, and pharmacies. For elderly individuals, those with disabilities, and those in rural areas, access to transportation means the difference between receiving care or not. Without transportation, many individuals would miss critical appointments, leading to worse health outcomes and increased long-term healthcare costs. We must ensure that transportation is not just an obstacle to care, but the bridge to health and well-being. Medicaid cuts, particularly to NEMT, would have devastating impact on vulnerable Vermonters. If funding is reduced and membership eligibility reductions without corresponding demand reductions, services would likely need to be cut back. The result would be increased health risks, higher healthcare costs, and an impact on rural communities. Managing Medicaid transportation involves significant administrative burden. Regulations require extensive paperwork, verification, and reporting. And all of these tasks take time and resources away from direct service delivery. Additionally, high utilization individuals, those with chronic health conditions requiring frequent transportation, use a disproportionate share of resources. While these individuals need these critical resources, they strain our systems, requiring more rides while consuming more administrative and financial resources. Balancing these needs is a challenge, and cuts to regional-based services, membership reimbursement, and braided ratios would only intensify this issue. One way to address these challenges is by expanding braided services, which integrate different transportation funding streams and services. By combining Medicaid-funded rides with other state and private transportation resources, we can provide more flexible, cost-effective solutions to meet the needs of all Vermonters. Braided services help maximize resources, improve access, flexibility for high utilization individuals, and reduce administrative cuts. As regional transportation providers, we are well positioned under the braided services model to assist in addressing these valid concerns. And targeted investments by the legislature will allow us to, one, address the gaps in our service eligibility with funding supporting a Mobility Plus model. Two, increase our volunteer capacity and increase cost efficiency through funded dedicated volunteer recruiters, addressing volunteer eligibility inconsistencies between programs, and adding volunteer driver opt-in opportunities as part of the state administrative process. An example of that would be a opt-in checkbox during the DMV process. It also, three, allocate state capital funds for vehicles to pilot community cars programs, providing volunteer opportunities for individuals without viable vehicles of their own. And four, support the development of a community driver classification. This is an employee, an individual of the company that can be paid by an hourly rate while driving their personal vehicle. Thank you again for your time today. Transportation is integral to the Vermont's healthcare system, and without it, many of our most vulnerable residents will suffer. I urge you to consider the long-term impact of Medicaid funding, healthcare system adjustments, and help ensure that every Vermonter can receive the care they need. I look forward to answering the questions you have, and I thank you for having public transportation represented at your hearing today.
Thank you, Caleb. Great. Do we have your I think your testimony is on the transportation website.
The Vermont Public Transportation Association has also included a comprehensive document that has recommendations for funding sources, how we would spend the funds, and an analysis of categories like high utilization individuals, some of those kind of high stressor elements of the public transportation system.
Can you just share with us, because we're on this committee over here, who's on the committee that
is reflection of a number of studies that have been created for both healthcare committees as well as transportation committees over the past 3 sessions.
Thank you.
Thanks. Welcome home, Stephanie.
I'm Stephanie Barrett. I'm the financial director at DEVA. And this is Grace Johnson. She's a policy analyst, and she's been involved in the non-emergency Medicaid transportation program. And so I just wanted to say right off the bat that there aren't any immediate Medicaid cuts being considered. I know the environment that we're in at the federal level is a concern to folks, but that's not, there's not an automatic reduction stayed right, so to speak.
I hate cutting, but what I would say about that is with less volunteer drivers than before COVID, starting from a lower base and the place, and with changes in in the whole medical system right now, hearing dialysis being cut back in a number of different places around the state, we're already seeing a shrinking of services. And with the possibility in the future of, and all the noise out of Washington, we can't just flip a switch and get more transports. So unless we start to build from a base, there's a work.
There is a capacity tension, clearly. Yeah. So Grace will start out with the high level overview of the NEMT program, and then I will speak to the procurement, how we procure the service at DVHA.
Thank you. I think we've got the slides up now. So like Stephanie said, my name is Grace Johnson. I work as a Medicaid policy analyst over at the Agency of Human Services. We wanted to start just by giving a high-level overview of the program and the federal requirements that govern the program so that hopefully then we can dig into the funding. So as many of you probably already know, the Non-Emergency Medical Transportation, or NEMT program, provides rides for Medicaid members to and from Medicaid-covered services with a Medicaid-enrolled provider. We're really talking about a very specific subset of rides when we talk about the NEMT program. The NEMT program is designed to ensure that Vermonters can access essential medical services and utilize their Medicaid insurance benefit. State Medicaid agencies have some flexibility in how they administer their NEMT benefit and how they pay for and provide rides for members. The single state Medicaid agency is, however, responsible for ensuring transportation meets all statutory and regulatory requirements, regardless of how the state manages the delivery system. So we currently administer our NEMT benefit through a broker system. As you've heard, we have one statewide contract with the Vermont Public Transportation Association, VPTA, to administer the NEMT benefit to Medicaid beneficiaries across the state. VPTA, among many other things, determines program eligibility, assesses what kind of transportation an individual might need or be eligible for, subcontracts with transportation providers across the state, schedules rides for members once they've been found eligible, and then resolves challenges between providers and members. Let's see, not used to Zoom. So before we dive into the details of the program, it's important to understand the landscape that the program sits in. As you may know, Medicaid is a joint federal and state funded entitlement program that finances medical services for a diverse population. States operate their Medicaid programs within broad federal requirements, and Vermont's NEMT program is no exception. The NEMT benefit has been designed to ensure we remain federally compliant, and all federal funding is contingent upon meeting these basic requirements. NEMT specifically is subject to rules and regulations from a variety of federal departments outlined in a myriad of legal documents, which I'm not going to get into. But the requirements are extensive and rapidly evolving. At their core, they exist to ensure states operate a cost-effective and efficient Medicaid program, and most importantly, ensure that Medicaid members are receiving the same level of care as all other individuals across the community, and that the care is reliable, consistent, and safe. These requirements can often feel burdensome to state Medicaid agencies and to providers, but they're non-negotiable, and it's our job to work within those requirements with our providers to provide the best level of care that we can. We've highlighted here some of the federal requirements. These are clearly not all the federal requirements that govern the NEMT program, but they speak to some of the core tenets of NEMT and do shape how we administer the program. The largest overarching federal requirement is that DVHA must ensure individuals can access medically necessary covered services. This is what we call our assurance of transportation, and it's the underlying driver for the NEMT program. All states must ensure that individuals who would otherwise be unable to access services have transportation to those medically necessary Medicaid covered services. It's also required that we, as a state, use the least costly method of transportation that is most appropriate for the needs of the beneficiary. This federal requirement dictates what types of transportation may be reimbursable by Medicaid, and this is how DVHA and VPTA determine what type of ride someone will get. There are also other federal requirements, such as nearest qualified provider. The federal government has determined it is not proper or efficient for Medicaid programs to transport individuals lengthy distances for care when there is a closer qualified provider. Provisions like this one are meant to reduce fraud, waste, and abuse. And then lastly, as an example, DIVA must, as for all other state plan services, ensure that Medicaid members receive high quality and safe care from qualified providers. This can be implemented through background checks, provider agreements, and more. Every part of the NEMT program is designed to fit into and comply with these federal requirements and all other state and federal requirements that govern NEMT. As I noted on the last slide, the NEMT program has been designed to meet these requirements, and it starts with our benefit design and eligibility criteria. When someone has an appointment and needs transportation, they first reach out to VPTA. VPTA then works with the members to determine if they're eligible for NEMT. So they check that a member is enrolled in Vermont Medicaid, which is our threshold requirement for NEMT. If that person's determined to be enrolled in Medicaid or Dr. Dinosaur, then VPTA determines if the member has other transportation available. They do that in a couple different ways, as we've heard, by checking to see if someone has a vehicle in their Medicaid household, if the vehicle is registered to the member in working condition. These checks are in place to ensure DIVA meets that assurance of transportation requirement. If VPTA determines the member has no reasonable means of transportation, there are no free transports available, then VPTA will verify that the member has an appointment for a Medicaid covered service with a Medicaid enrolled provider. They also verify the service is billable to Vermont Medicaid, and in some cases that the appointment has been deemed medically necessary or has received the appropriate prior authorization. At that point, VPTA determines what type of transportation is most appropriate while considering the needs and circumstances of the member. This could include demand response, rides, fixed route public transportation, or volunteer drivers, for example. VPTA will also ensure that the member is seeing the closest available provider, and then VPTA will help to schedule that ride. These steps ensure that DIVA is administering a cost-effective and efficient program and limiting fraud, waste, and abuse. We're walking you through each of these steps to demonstrate that each part of the program and each step that VPTA takes has a purpose. Each eligibility criterion is in place to meet a federal requirement. Through the NEMT program, DIVA and VPTA coordinated over 312,000 rides in state fiscal year 24, and we're anticipating just slightly fewer rides for state fiscal year 25. These rides have helped serve over 6,600 individual members.
So the last slide is mine, because I always just talk about money, apparently. So I'll talk how we actually procure the service. As Grace mentioned, it is a statewide contract between DIVA and VPTA for the NEMT program. And so the public service, the transit agencies are the subcontractors under VPTA. And so while the nuances of the requirements that VPTA does, those are also on the subcontractors for determining eligibility and all the details of whether or not that ride can be provided, notwithstanding the capacity challenges that do exist statewide. That contract is in place through the end of June 2026. We got an extension, but we will be going out for an RFP for the NEMT program coming this late spring, summer. So there's no room left to extend the current contract under our state and federal obligations to bid services. So that this conversation is timely in terms of informing how we frame that RFP. And there's been lots of conversations about the service between DIVA and VPTA over the past several months. The total cost that we have paid last year for NEMT has been $15.8 million. That's targeted. It looks on track to be at $15.7 million for 25 by the time we get to end of June. The way we pay for the service in this contract is a per member per week rate. That's not a per ride structure. And it has a look back period in it. And so any eligible member who has accessed a ride in the past 365 days is part of that weekly count that we pay. The rate is $45.80 per member per week. And that has very much a smoothing effect of the way the services are, the way the rides are covered. So we have members that have multiple rides in a week potentially, and members that may be accessing a ride only once or twice a year. But But if that member is accessing the ride once or twice a year, they're still we're still paying VPTA $45.80 a week for as long as they're in that count. And so that's been a longstanding structure of the way we've done this. I don't know if that will change coming out of the RFP or not. But I know the interest of the committee was to understand how we pay for this service. And that's a part of the way we have been doing it, and we'll be doing it through the end of June.
The look back. Can you just talk about the look back?
The look back is about the count of people that we pay that weekly rate on. So it has to be a member that has accessed the NEMT service. They have to be an active Medicaid member. They have had to access the NEMT services in the past 365 days. And so that's how the count weekly that we pay this rate on. And this rate goes to VPTA, and they are the ones that then pay the subcontractors. Also within that rate is their administrative overhead. So that's the overall picture of our financing of the program. To the extent if capacity magically appeared and that and we serve more people, we would pay that same rate on more people. We're telling you what we see right now based on the capacity that the system is providing. So the rate is the driver. We're not locked into a total amount. It's how that rate and that the count per week turns out. And that's what we're seeing is we're in that $15.7 million total of the NEMT program. And that is matched at the, roughly 42% state funds and 58% federal funds.
So is this part of our basic Medicaid or is it part of our waiver?
It's a state covered service. So it's part of our Medicaid state plan.
Just our basic Medicaid. It's not part of a waiver. We don't have to ask permission to increase numbers or change. Would we have to ask permission to include emergency drivers or other organizations, or would it have to stay the way it is? So right now you have an NEMT, you've got the program, and you've got you send an RFP out, and you get it back from VPTA, right?
Or other bidders. It is a process.
If we were to change the requirements for who's driving and maybe have different sets of requirements and a separate contract that would include emergency drivers or other community drivers, that wouldn't make a difference.
I think we'd have to go back.
Go back and look at it.
Yeah, you start blending the emergency transportation and the NEMT.
Yeah.
I don't know that. I don't know. We can't answer whether that's possible or desirable or.
Well, no, we don't know any of that, but yeah. But it is part of our basic Medicaid.
Yeah, both the NEMT and emergency transportation are state plan services.
What relationship, if any, is there to the SSTA program that we have for Dale disabilities?
It's
not.
If they're a Medicaid enrolled person needing a ride, is that under a separate? I'm sorry, I'll have to double check.
Okay, that would be.
We do. If they're Medicaid eligible and the ride is eligible, it's under this contract.
Okay, but so it could go through a different vendor. So someone who has a.
And I do believe there are subcontractors with VPTA that are SSTA.
Got it. Okay. Yeah. So subcontract.
We're done.
We're past your time,
Okay, we need to leave.
but if you'd open it up for a question or two if you.
No, I think this is great. We'll continue working on this. We talk about these issues off and on in our committee, but it's nice now to have a focus with both transportation and Medicaid and potentially others and providers. So I look forward to continuing our work together. This is really great. Thank you. We're going to leave disappointedly so and go back to our committee.
Thanks for joining us.
For having us.
I will say that Senator Harrison is on the screen. She's not feeling well, so, but she is here with us. So
Great, thank you.
Thank you, Senator Harrison, for being here. Take care. Maybe bring it.
I think with the number of rooms, is this room available? So why don't we just stay here?
Oh, okay.
And there's enough.
Oh, okay.
So I think what we're going to do is we're going to remain in this room because the room's available. And
Yeah. Got trouble.
as soon as
Okay. You want to do that? You want to bring it off or pull out? No, what do you want? I was just doing it. I know.
Senator.
oh, it is.
Want to move? Oh.
Um,
It's available till 10:30.
Till 10:30? Why don't we just continue?
Until 10:30.
Yep. This room is available till 10:30. We're gonna remain here. At this point, what I was thinking is, I do know that, the public transit people met in their association. They do have some recommendations.
Yeah.
So this might be a good time for you, Caleb, to, put what is on the table. The whole discussion about Medicaid funding and, all of the piece. It would be helpful if, but one or both of you could stay and we're sure that you'll have, because we're going to have lots of questions. So Caleb, why don't you tell us what, because I knew you had a meeting on Wednesday.
Yes, and Stephen Falble is also available if we want to send him a participant link. He's assisted in the data preparation of the recommendations that you have in front of you. But, just to kind of reiterate my earlier statements, I think what I'm hearing from medical providers and what I hear in our communities, oftentimes the discussion can focus on Medicaid. At RCT specifically, about 65% of our funding and a great deal of our rides are related to the Medicaid program. But under the braided services, you have an opportunity to leverage the transportation system as a whole. So, the 2 points I'd like to make. One is some strategic investments that we can make to increase efficiencies. And the other is a holistic discussion on braided services and how to kind of make sure that we're addressing some of the concerns brought up by healthcare providers about individuals who may not meet the many Medicaid eligibility, either through vehicle eligibility, appointment eligibility, or program eligibility. There's a number of individuals who fall to the bottom of the Plinko board of all the various funding sources and find themselves without transportation available. So through our association, the recommendations we've come forward with of investments is focused on increasing efficiency through a number of new programs. The first is really building out the volunteer driver program through coordinator positions, both in recruitment and in management of the volunteer program. It is an intensive process of going into communities, identifying individuals, verifying their eligibility through background checks, verifying their vehicles are appropriate for transportation, and then managing to ensure quality and consistency of that transportation. So an investment in coordinators for the volunteer driver program is critical, but by most estimations could pay for itself over the long term. Other program recommendations are an investment in a community cars program, which is for individuals who are either uncomfortable or have an inappropriate vehicle to participate in the volunteer driver program. The third recommendation is a assistance in creating a community driver program. A community driver program is a new form of employee where individuals would drive their own vehicles and be an employee of the transit agencies. This obviously has significant impacts on insurance,
And there is a number of kind of legal analysis that would have to lend itself to creating a successful infrastructure for this. But it does address one of the big downfalls of the volunteer driver program. You have organizations like SSTA in Chittenden County. Exceptional service, very well-run organization, but there's little to no incentive for individuals to volunteer within a Burlington area because so many of the services are right there. So you drive 2 miles, you drive the individual off, you wait for them to get picked up, and all of a sudden you've made a whopping $1.50 for the morning of your time. Whereas an RCT has experienced a lot of our success in the volunteer program because we're driving people to Dartmouth, to Boston, to Philadelphia, to Albany. All these trips can mean significant reimbursement for volunteer drivers. The community driver program, which it's not a reimbursement structure, it's a compensation structure on an hourly basis, really helps address that concern there. So you have those critical investments in 3 forms of program. I also want to mention what we have come to term Mobility Plus, which is really addressing those individuals who fall between the cracks of all of our various funding programs. They may not be Medicaid eligible, or their trip may not be eligible. They are neither an older adult nor a person with a disability, but they don't have transportation. And so they find themselves without opportunities. That can be addressed in a new funding source, like a jobs and recovery funding source, where an individual, when they call a regional provider, can reach out and say, hey, I need a ride. And typically the way that conversation goes is we go through our various eligibility of funding programs. And if we get to the bottom of that and we have not identified a program they may be eligible for, the vast majority of the time that individual goes without that transportation. So finding some sort of gap funding and eligibility. The other way you can address that is through expanding microtransit. Microtransit has seen great success in the Northeast Kingdom, and it brings to individuals the agency and the flexibility of a low barrier program where they can access things like socialization, emergency or urgent care. They don't have to give notice. A ride can be available within 5 minutes, and they can get to wherever they need to go, depending on what they see as their needs. So those are 4 overall categories of places you can invest to increase efficiencies and address some of the deficiencies in our transportation program.
Awesome. Megan?
He's on the phone.
Did Stephen want to talk?
I think Stephen was available. He assisted in preparing the document you had provided in preparation for our testimony, which outlines the specifics of some of the data analysis, funding recommendations, as well as targeted investments for the Senate Transportation Committee to consider.
Okay.
The checkbox, did you get that idea from another state, or was it just an idea that we had locally?
I think, I don't know the historic context of it, but it's been in discussion for the entire time of my tenure to try to figure out ways to encourage individuals to self-identify as potential volunteers. And
I like that idea. I just didn't know if there was any, we were modeling it on a successful program from somewhere else.
I'm not familiar with one. I know this has been an initiative discussed by Representative Noyes at a number of junctions. Yeah.
Are we open to more?
Yeah, absolutely.
Okay, we're open now. Okay.
We were under time constraint to get with, and they went past in time, but go ahead.
So, okay, so can I ask questions of anyone who's spoken before?
Yeah.
Okay. Just trying to get my P's and Q's. Okay, so I have 5 questions that I've been percolating on since the testimony started, and you're not necessarily the right person for all of them. So you had actually brought up the first one in your testimony that you provided to us and previously in Senate Transportation, and that's the idea of a mobile unit, either for dialysis or other kind of consistent chronic treatments that need to be a part of someone's reasonably everyday life. And I'm wondering, that question was more geared, I was hoping the Gifford folks could respond to it, because that was highlighted in your testimony, and I didn't hear any conversation about that with the healthcare providers. So I'm wondering if they've considered mobile units. I know you've talked about it. Where is that, and why aren't we moving forward with that idea?
Would you like me to frame it to give context to my colleague?
Sure.
The mobile units is really an outcome of our analysis of the high utilization individuals, looking at population dynamics and seeing concentration of individuals who we are transporting longer distances on recurring basis. So we have identified that as a disproportionate utilization of our services. If you look at our service specifically, about 45% of our transportation is taken by about 9% of our riders. So if we can do a thorough analysis and think of innovative solutions on how to address that specific population, it would relieve a lot of the demand of the transportation system as a whole. And with that, I'll pass it over.
Sure, Devin Green from BUDS. We actually have had a lot of discussions around dialysis, in particular with our chief medical officers, and trying to understand where we can better serve people with dialysis. And we have talked about mobile units. I think it's something we would like to explore more and further.
Okay. Yeah, I think that's a win solution. I don't know how we do that. If anyone has suggestions on how we do that, if you need us to do that, I'd be very open to it. Okay, so my next question is around the Medicaid eligibility. So I don't know if it's you. So my mom lives with us. She's on Medicare and Medicaid. She was kicked off Medicaid when she got Medicare, but we had to do in-person meetings and filled out a lot of paperwork, and she's now back on Medicaid too. She lives with us, but both my husband and I we're a one-car household. We are trading off our own car and we work. So does that count as a car in the home? Because she wouldn't be, I'm not able to drive her. My husband's at work. We're all working during time. So is she eligible? If someone has a car in the household, this is an example.
Yeah, so every scenario is different, but when we examine the availability of a car, when BPTA examines the availability of a car, they do look at whether or not that car needs to be used by someone else in the Medicaid household. So that is something that goes into consideration by BPTA.
Okay, so even if there's a car in the household, if that car is being used somewhere else, you can still qualify for Medicaid, right?
Yeah, it's not an automatic disqualifier. They also look at insurance status, whether the car is drivable, all those things, so.
Cool. Thank you. That's really helpful. That was a concern for me because there's a lot of folks who are in that exact situation. Then my next question is, all of this stuff costs money. And we haven't had any clear push for finding a revenue source, at least on our committee at this point, I would argue. Maybe I misheard. It's not in the T-bill. Where do we get the money to fund this? Are there recommendations for that? I've put out the idea of a delivery fee that we got from the transportation funding study, talked about indexing the gas tax, talked about a whole host of other things. Are we percolating around a funding source that this group is recommending, or is it, here's what we need, you figure out the funding source still?
So from a VPTA perspective, obviously our recommendations to the transportation funding study would be the leading document for reference there. But I will share that the document that was provided in preparation for the testimony does have more specific recommendations based off of that study. I would also, reiterate that these are investments in efficiency. And hopefully will kind of seek either to offset increases in the future or to offset the initial investments to gain those efficiencies.
Yeah, it looks like you've identified the retail delivery fee as your first, then a vehicle registration fee, a utility fee, and then a rental car tax. Those are the four that you've identified. Yeah, I guess I would just note that if there is support for this, it's going to take revenue. Yeah. And then the last question I had was more around the microtransit piece, which is my understanding is we're losing most of our microtransit at the end of this year throughout the state. So all the pilot programs throughout the state are ending, I believe, their funding, but I'm happy to be corrected on that. And I know we have someone from AOT here, but those programs are going away, I believe. Or no, they're not going away. They're being extended.
So
Maybe what's going on there?
So portions of those, so some of those pilots are coming to an end. At the end of any pilot program, we look at efficiencies and we look at population dynamics to make sure that those programs still make sense. For a specific example, RCT currently runs 2 microtransit programs, and those were replacing 5311 programs, which are a 50-50 program within the state, and move those over to CMAQ, which is 80-20, which means there's more federal funds supporting those, which make them a little bit more sustainable moving forward. Microtransit pilots under the MTI program, which was a short-term investment. So it's a combination of looking and evaluating programs based off of their efficacy, a funding liability as far as whether it was long-term funding, and an analysis of success. So I would say, kind of wholesale, they're not being eliminated. Each program has been analyzed individually.
Okay, but okay. So do we have a list of what's going away and what's staying? I know that the Windsor area, for example, has a program, and I believe it is ending at the end of the year, but I'm not sure. I'm happy to be corrected.
Those may be premature. Those service fluctuations will be reflected in this year's subcontractor grant application for VTrans. So that will outline the specific.
We're being kicked out, so think we're okay?
I think you're okay. We moved to the other caucus across the hall. And unless there is another caucus that will I'll try and avoid that.
It would be easier if we could stay here,
Yes.
but we'll move to transportation if we have. That's good. So I do have a little backup question, and this I think is we can, and this is to more back to the basics of why we need to move into this era. Consistently hear about canceled appointments in hospitals and last minute and could you talk a little bit about that that issue and what's going on in the hospitals around appointments and the last minute cancellations and what's going on in that?
Okay, so my name is Ashley Lincoln and I work at Gifford. I would say part of my role is patient relations, and that means oftentimes patient concerns and complaints. And we often, my office can receive a lot of phone calls with patients who are struggling to find transportation. And we are very fortunate to be able to collaborate with Tri-Valley Transit, which provides transportation to support our needs. We have a health center in Chelsea and one in Rochester. And as you're well aware, those are mountains that you are climbing over. And we have an elderly population. And what we see happening is that when a ride is canceled, it is short notice, which then means for us to be able to fill that appointment, we have to find somebody on a list that has adequate transportation to get to that appointment. And as you can imagine, if you're being seen in a Rochester or a Chelsea clinic, that could be problemsome. And now you don't have that appointment. That appointment time is now blank. And we're now scrambling to figure out how to get that transportation reset in order to get that patient who now has a wait time and could now start to have, you know, I'm not going to say significant, but additional healthcare needs, which now may require an ambulance. I will say on this line, my work also, I am working with Tri-Valley Transit and I'm working with transportation companies in other counties where we're trying to piece together a ride to get that patient to where they need to be. Having patients that come to our organization from different towns. So it can be meeting at park and rides, and having a patient have to be at one park and ride and then get them to a second park and ride to get them to where they need to be. We certainly do not want to have to rely on an ambulance because that takes them out of a potential emergent situation. But we sometimes do reach out to our local police to support our needs as well. Because we just don't always have, which now takes them out of their service area, transporting a patient that needs a ride as well. I don't know if that helps.
That's very helpful.
Devin Green from Baz, and just to add, there is an access and financial component to all of that. So with that missed appointment, then that is time that a provider is not spending with a patient and sort of wasting time. And so there's that piece as well. And Senator White, I looked back.
Very helpful.
I looked back at my notes on the dialysis, the mobile dialysis units, and it looks like when I spoke with the chief medical officers, we talked about the need to have 5 or 6 around the state. And they would require teams of nurses and telemedicine. So it would be a significant investment, but it may be worth looking into. I think the barrier we're seeing there is workforce potentially.
Go ahead.
Well, I've told this particular story a few times, but when I introduced a bill around transportation demand management strategies being funded by our largest employers back in pre-COVID days, the first lobbyists who showed up to disagree were the hospital lobbyists, who said we could never support this because the cost as a large employer, we couldn't do it. We couldn't telecommute. We couldn't rotate schedules. We certainly couldn't have people work from home. And then within 3 weeks, we had COVID and all of that shifted and was made functional. And it was a really big eye-opening experience for me because it made me learn that when push comes to shove, we can make great changes. And it was something that has stuck with me for a long time. So I do hope that the hospitals support revenue sources, because to avoid costs like having to do mobile units on your own, we could certainly fund greater access to care through things like transportation demand management strategies, where you have to pay as a large employer to support places like CATMA or other transportation authorities like what we have in our area to then fund the programs that you're asking for. So I do hope when we have S-146, hopefully we take testimony on that, maybe not this year, but in the future, that perhaps the lobbyists from the hospitals could come in a little softer.
Well, just to be clear, we're not asking this committee for funding for dialysis units, mobile dialysis units. Again, the barrier there is workforce and logistics. But I understand what you're saying.
Caleb, and I see we have Jim Moulton, who is also on. And I see the focus on expanding the pool for volunteer drivers. The question I have, who recruits volunteer drivers? What does that effort look like? How is that focused? And do you have someone on staff that is out there looking for volunteer drivers? What's happening with that now?
So I can speak specifically to rural community transportation. Currently, the volunteer coordination is an aspect of our operations manager's responsibilities. We incorporate the volunteer recruitment into all of our community outreach, whether it be town meeting day, discussing appropriations, attending county fairs. We do an enormous amount of community outreach, and the volunteer recruitment remains a kind of underlining message of all of that. I'll be speaking with the community at Groton Library tonight. It's just sitting down and talking about transportation, what their needs are, what we provide, how we can better address that. And I will be handing out volunteer recruitment pamphlets at the very beginning there. So it's really, ingrained in everything we do. But as I mentioned before, the management recruiting of that could certainly be more dedicated as far as individuals who are specifically targeting historically demographic targets of that, whether it be Legion Halls or VFWs. Communities that have high volunteerism rates and individuals who are good fit for the reimbursement program. So at this point at RCT, it's just integrated into all of our systems, but I think an investment in a more targeted, again, would gain those efficiencies and pay for itself over time.
That's very helpful. Complaint we've heard as part of the reason DMV doesn't want to do a checkoff is there isn't any coordinated effort to get back to people. And if we focus that effort with, and there were connections between you and, say, DMV, that might be helpful.
That would be fantastic. I think especially if you coupled an administrative process like the DMV checkbox with an investment in volunteer coordination that would specifically address that issue. I will maybe ease some of your concerns. VTrans made a significant investment in recruiting community drivers or volunteer drivers over the past year and have seen a good influx of inquiries based off of that. And I say, a lower percentage actually pan out when they better understand the program. But, VTrans runs volunteer program advertisements in the St. J. Star movie theater. And I bet we get a phone call about, hey, I saw this and I'm interested at least once or twice a month. So there's certainly a return. And I think with intentional process and investment in coordinator positions, we can pay better homage to the inquiries that are a result of those programs, especially the DMV one.
Great one, thank you.
And RCT, how much of your driver is Medicaid related?
I would say the majority is Medicaid related.
Yeah.
If we did something to better coordinate the recruitment of volunteers in that space, is that something that would be Medicaid eligible? If we were to coordinate the recruitment of volunteer drivers, would that be Medicaid eligible for or at least a component of this?
There's a couple options we could research, but I think there is a portion of it that is, that we could match depending on how we design what the method by which we pay for it.
So for example, when majority of the rides in RCT's territory are Medicaid eligible, that could be wrapped in as a potential source.
So we have a statewide contract that we pay in EPTA.
Yep.
That would probably be the conduit, more likely than a separate structure that would be direct between. You want it to be embedded in the NEMT program to run a match. And so we just have to work through the logistics and mechanics of how that might work. It would take additional resources, obviously. But it's not, it's something that we can research. And I have sort of a high degree of confidence that we can land on something that would work.
And a year from now, we're gonna renegotiate that contract.
We're gonna go through this RFP process. That we have to.
I see that Jim is on.
Jim can go.
Yeah, Jim, do you want to add something?
Thank you, Senator Westman. I did want to say that TVT currently does have 2 volunteer coordinators, and because so much of the time and energy is spent recruiting and retaining volunteers who do Medicaid work, that it is eligible for and under our cost allocation process, part of those costs do end up under Medicaid. So if there were additional Medicaid funding, in other words, I think you're looking to answer, is it a cost sharing? Is there ability to cost share? Would it be just transportation dollars, or could it also be Medicaid dollars? And the answer is that it can be. It might need to be more potentially explicitly defined in the future contract, but it is an eligible expense.
Did you?
I had a question on the payment system. You talked about the $45 per member per week. What's the, who are the members?
The Medicaid eligible folks that are accessing.
Those are the members.
Those are our members.
Medicaid members.
Yeah, that was helpful to hear because we had heard it's around $50 per ride is the cost, I believe. So that's good to know. The reimbursement's close.
Well, depends on how many rides they take.
Yeah, so there, underneath that is a nuance in the cost structure for the public agents, transit agencies themselves.
I would be remiss if I didn't, because we've heard this problem that background checks and there's difficulty between some places there's 8 background checks, some later there's 5, but background checks have been brought up as something very challenging. Once you find somebody that might be interested as a volunteer driver, can you talk about the issues that you understand around that?
Yeah, so Medicaid requires the same number of background checks for all of our NEMT programs. I think you're referencing some of the Dale programs have a different number of background checks. Our background checks are consistent. Essentially, we are unable to waive any contractual provision between us and BPTA at this point that would require those background checks. It's really up to the BPTA to determine who they can and cannot recruit within those federal, state requirements and those contractual provisions.
It's all federal. Can you talk to us a little bit? What is the process for the background checks? How much time does it take? But they found a volunteer. What happens?
Yeah, I cannot speak to the timeline, but I'm happy to follow up in writing with how long that takes and check with our program folks.
Yeah, I think we did here. It was like 8.
It is an extensive process. And I think, to the point, I think there is inconsistencies across our program, which creates challenges for the braided services model. So I think, looking to relief or at least consistency within the VPTA DEVA contract and some of our other programs to ensure that we have a kind of equilibrium of expectation and background check analysis. But, the process by which we verify volunteers is extensive, and it can, become burdensome as you find and identify maybe long ago issues that may disqualify someone without professional judgment on waiver.
Is that anything we can fix at the state level, or is it mostly federal?
So VPTA does have some proposed statutory language for the Senate Transportation Committee to consider, but there are also contractual considerations, as my colleague over at DEVA pointed out. So that would have to be analyzed.
I'll have to see that language.
Be consistent with federal requirements.
Is that language you're referencing something that's a part of your proposal here or something we've seen? I don't know.
Part of the proposal in the memo.
Okay, well, you're next to the person who might do that, so.
Well, it would be helpful if we would all come together to talk about that, because we'd love to take a look at that. I think at this point, are there other people that would like to comment? Yeah. Did you want to say something Senator Harrison?
Sure, I have a question, but I guess what I would really like to say is this is a really good start. It's great to have the two committees together and have the administration folks and the providers all in one room, because it is a complicated system, but it's a critical system. So my question is, I know it's hard to know what you don't know, but can we, or can someone give us an idea of how many non-medical needs are there that we're not meeting? How many rides are we not providing? Or how many people are missing appointments? That would be very helpful information to have.
That is something we can follow up with. We do, at least at RCT, catalog every ride request. So we may not be able to quantify the number of individuals who pre-screen themselves before even asking for a ride, but we can share data as far as an eligibility of both trip and individual.
Great, thank you. That'd be great. And all of this information is really helpful. And what I heard was the contract expires in 26, but the RFP is going out in 25. So this is actually good timing to talk about how the services are provided.
Did
And that's not a question, that's just an observation.
the Gifford, did you want to comment on the question?
I just wrote a note for us to try to figure out, how many appointments are being canceled because of a lack of a transportation, and then we're just trying to figure out, do we have that already set in stone kind of in our system, or do we need to build a report? So we'll figure that out and follow back up.
And
Mike Fisher, healthcare advocate. So we run a helpline and people call us when they're having challenges with all kinds of access to care issues, including transportation. And I've been listening to your hearing this morning and did check in with our data for the last 2 quarters. And interesting, so traditionally, non-emergency Medicaid rides a place of tension. Things go wrong, people are frustrated. We usually get a pretty steady flow of calls of people who are caught up in one thing that's not working or another. I don't know how to explain it, but just FYI, recently we are not seeing a lot of calls.
Wow.
So that's a good sign. And I always caution, the universe of people who have problems with a particular issue, how many know to call the HCA, probably relatively small, but it does give a little insight that we're not seeing. We're actually seeing less calls recently than we were, a couple of years ago.
If I could just add some kind of contextual reference when it comes to transportation cancellation, working with northern counties, we did do an analysis of individuals who had identified canceled RCT trips as the reason that they weren't able to attend an appointment. And of the 50 instances provided to RCT to review, because we record every conversation we have, so we know whether we're calling people to cancel their trip, and only 2 of those were RCT cancellations. So I think there is some complication to the narrative of kind of transportation is a convenient reason of why you can't make appointments. But I think we can do analysis and figure out both cause. And I think the other part that I wanted to just highlight in that conversation are the challenges of kind of last minute cancellations for one individual means an opportunity for another. And given capacity, localized transportation providers can, be more responsive within that 40-hour notice.
Go ahead.
I did just want to point out, one thing that's tough about this conversation is I think it's also a reflection on just community fabric breaking down, which is a really sad reality. But during COVID-19, I was a part of a mutual aid group that did constant rides because people were not able to get to Dartmouth. They were not able to get to there's lots of Dartmouth clinics, all of the different locations, because they either didn't feel safe taking the bus or the bus was not available anymore to them. So there were a whole host, at least in our area, of mutual aid efforts that kind of sprung up in response. And I know there are still people who, like Kim Souza in Hartford, she still drives Pam every week to her appointments, you know. And so there's these connections that are created on a one-to-one level that are also really valuable. And I think we've lost a lot of those supports for our older Vermonters, which is really sad. And so I do think that there are ways that we can support that mutual aid aspect as well, by connecting people who are already going to an appointment, carpooling. I mean, that's where Go Vermont could factor in, because there's lots of other ways versus just going to public transportation or using a service. You can use members of your community that you've built connections with to do that. So I do hope that as we continue this conversation, we think creatively about connecting to that network of people, because we're going to be relying on them as services continue to be unfunded by the federal government. So just wanted to note that.
I would just say, I see people in the transportation agency here. And clearly what I get out of this, we need to better coordinate the effort to shine a light on how we get more volunteer drivers, how we up our game and do it in a way that is better coordinated around the state and focused. And I think our next step in the committee is going to be just put some proposals out on the table to focus those efforts, to particularly get coordinators to help. And that's going to take efforts both from our transit agencies, the agency itself, and with the providers, how we can better coordinate between each and work out those schedules. So this flow works better between all of them. I am with the ever shifting balance and the reports from the Green Mountain Care Board about the consolidation of service. And we can't wait till it all begins to consolidate. You don't just find a volunteer driver. So I'm a little bit in the position that we need to act now to at least create first steps towards someplace that we can coordinate this effort better. And what that will mean over the long term is a shifting funding sources. And I think it's probably a really good time with the contracts that will be renegotiated in a year from now. But in this time, I'd like to see us get ourselves ready for that. Did you?
Thank you, Mr. Chair. You went exactly where my head was going. I heard how you kicked off the meeting with a discussion about contracting services. And then, and I can't tell you, I've heard every bit of this morning's testimony, but I heard a lot of discussion about how it's functioning today. And I thank you for coming back to that first topic, because I think we have substantial risk for loss of services in various communities around the state. And so I think, and transportation needs a seat at the table as we figure out, sort of how to get people to care. So, and I guess I'll just say, we of course don't know how it's going to play out, but there are scenarios where volunteer drivers is not going to cut it. And we're going to have to think about something much more substantial to make sure Vermonters get the care they need. So I really want to thank you for this conversation, and I'm afraid we're going to be.
It's my goal to work with my committee members, and I think the agency will be looking for some help to think about how do we kick off doing a better job recruiting people. I could see some people that are volunteers that we recruit that might, for longer trips, we might find a way to compensate them going forward. But unless we have workforce and people willing to do these trips, unless we start gearing up our effort around that, we've got no place to go. So at this point, this went a little faster than I thought.
Can I ask
And
more
we
questions?
are, what?
I'm happy to ask more questions.
Well, I want you
I
to
can
ask
keep going.
your questions as much as you are. I do know that this room was only booked till 10:30, but keep asking until we get booked out.
Yeah, I guess my only final question would actually be for you,
Yep.
which is we've gotten a pretty detailed proposal from our friends in the public transportation system. Would it be all right for me to ask legislative council to start drafting parts of their memo to us into legislative form to review as a committee for this year?
I think that what the next step, the agency's here. I'm gonna look for a proposal from the agency to address some of the central pieces of that. And the coordinator piece to me is the first step in that. And then, we're gonna be talking about this going forward. So the drafting of what some of this is, will carry on long beyond what we can get accomplished between the now and the end. But the next step I'm gonna look for our committee is to hear from the agency and what's the first steps to get something started in this. And, we thank you for the proposal. We're gonna, be going through this and working on that. But I will look, next week, we're gonna need to hear from the agency with a proposal from them.
Okay.
Stephen?
Yes, Senator, thank you. I just wanted to make one comment to slip in at the end here, and you've been talking about this theme. Certainly the theme of the day is the intersection between healthcare and transportation, and talking about scheduling. And I just wanted to sort of add one comment. There are three parties involved when we talk about transportation and healthcare. There's the patient, there's the healthcare provider, and there's the transportation provider, and they all face questions of cost and convenience. And just to bring up sort of a theoretical situation, you have two people who need dialysis treatment who say live within half a mile of each other. And in an ideal world, those patients would be scheduled for dialysis on the same day, Tuesday, Thursday, Saturday of each week, so they could be taken in a van together, which would essentially cut the transportation cost in half. That rarely happens, that kind of coordination. And the transportation providers have been saying for years, it would be great if our partners in the healthcare sector could take into account these geographical questions of where patients live. Now, we understand that frontline staff at healthcare providers have a huge amount to do and don't necessarily have the time capacity to think about those questions, but we're talking about real money savings here if that kind of coordination can happen, and if thoughts about scheduling can take into account a transportation coordination. And you know, I'm not here to dictate what the healthcare sector does, but the legislature is in a position to perhaps introduce mandates that sort of consideration happen in terms of patient scheduling. And that may mean that there's some degree of inconvenience for the patient and or the healthcare provider. But if we're talking about significant savings on the transportation side, that produces more money available for other purposes. So it's something, it's the cost, the trade-off between cost and convenience, and it's thinking about transportation and healthcare as partners in this whole effort to provide the best possible service overall. So I just wanted to put that out there as a consideration. Thank you.
Thank you, Steve. At this point, I think we're gonna wrap up. And if my committee members could show back up in the transportation room at about 11, we will talk about the rest of the morning, what we have to do for next